So welcome everyone. Welcome to this briefing event on the role of private equity in healthcare. My name is Brandon Novick. I'm the Program Outreach Assistant at the Center for Economic and Policy Research, otherwise known as CEPR. I will be a moderator of this event, but also a panelist. But first things first, I want to thank our co-sponsors. So along with CEPR, we have the Private Equity Stakeholder Project, United for Respect, the Open Markets Institute, the American Economic Liberty Project, and Americans for Financial Reform. And of course, this entire event would not be possible without sponsorship by Senator Warren and her team. So we want to thank them as well. I want to give a roadmap for how the briefing is going to take place. So after I am done giving this introductory remarks, which I'm sure you'll all be ecstatic about, Senator Warren will be joining us to give her own remarks. Senator Warren serves in the Senate Finance Committee and the Special Committee on Aging, where she is one of the leading voices shining a light on the role of private equity in healthcare. She's also introduced several bills like the Stop Wall Street Looting Act, and most recently the Corporate Crime Against Healthcare Act, which the latter of which I'm sure she will speak about when she's here. After she gives her remarks, we'll move to our panel. First up, we have Dr. Eileen Appelbaum, my colleague and boss, who's the co-director of CEPR. Eileen has written extensively on the role of private equity in healthcare in areas like hospitals, hospice, autism services, and more. She's just generally an expert in private equity in general. You might know her 2014 book, which she co-authored, called Private Equity at Work: When Wall Street Manages Main Street. I encourage you all to read it if you have not already, to understand generally how private equity functions. After Eileen, we have our other expert, Eileen O'Grady, who is the Director of Programs at the Private Equity Stakeholder Project, and also a CEPR alum. Eileen has helped lead PESP as the premier nonprofit organization shining a light on private equity across the economy, including healthcare. Her work has been essential in my understanding, CEPR's understanding, and basically everyone else's understanding of how private equity has impacted the healthcare landscape, and it's especially impressive considering how opaque the landscape is and how hard it is to skip information. After they both speak, you all have the potential displeasure of hearing from me. I hope not. I have worked with my CEPR colleagues, not just Eileen, but Emma Kirchen, who's here. I've worked on helping research the role of private equity in healthcare, but you may have also seen an op-ed of mine in the Hill on private equity and transparency. That's what I'll be discussing today. After that, we want to leave ample time for questions you might have. I really encourage you to ask any questions you might have, however broad or specific it is, because if you don't, you'll field my questions, which I came up with to ask both our leads here. And I think they're good questions, but this is for you all and not for me. To help, I guess, give a foundation for the briefing and maybe help also with any questions you might have. As you know, the title of the briefing is the role of private equity in healthcare. Some people criticize the scrutiny that groups like CEPR and PESP put on private equity because it only owns a minority of healthcare providers. That's true. It only owns a minority of healthcare providers. But private equity also has invested over $1 trillion since the 2010s in healthcare. It's not chump change. And it also kind of misunderstands how healthcare works. Healthcare providers are constrained in specific local or geographic areas. And what private equity does is it seeks to acquire, dominate, and consolidate these local markets. And so we've seen across the nation in various communities, private equity's impact on the quality of care, the accessibility of services, and the cost of care. And due to the nature of the healthcare market and a complete lack of transparency, patients are not left well equipped to deal with private equity's impact. Just take Steward. The PE firm Service Capital Management bought 6 nonprofit hospitals in Massachusetts in 2010, which became the Steward platform for hospitals. And it did so through a leveraged buyout. The process of private equity only putting up a minority of the money to do the acquisition itself, the rest of it coming from, or much of the rest of it coming from debt which the private equity firm isn't actually liable for itself. No, the company it buys, or in this case, the provider that patients rely upon, is liable for it. And in this case, it wasn't even the biggest deal with Steward. There's much bigger leverage buyouts that occurred. But also in 2016, Cerberus sold Steward's hospital's properties for $1.25 billion. Almost $500 million of these then went in dividends to its investors for self-enrichment, And the deal also helped them acquire more hospitals. You know what happened to the actual hospitals that people rely upon? Well, no, they then had to pay rent on the properties they want to sell. And it's these types of things and other tactics that you might know that Steward declared bankruptcy. But what about Cerberus? Well, Cerberus made out okay. They exited in 2020, having profited almost $800 million over their ownership tenure. So Cerberus made money, hospitals are closing, and patients are suffering. Private equity is unique. This is not to say that there aren't other issues, but it's a unique problem. And with that, I am very happy to introduce Senator Elizabeth Warren.
Thank you for having me here. Well, there's always something going on. I just want to say a very special thank you to the Center for Economic Policy Research, Private Equity Stakeholder Project, and all of the great organizations that are hosting this discussion. Private equity poses a unique danger to our healthcare system. In just the last 10 years, private equity firms have spent nearly $1 trillion on 8,000 healthcare deals. They are squeezing profits out of every link in our healthcare chain. Unfortunately, I have seen this firsthand in Massachusetts with Steward Health Care, which along with private equity and corporate landlords looted 8 hospitals in our state. And this is the reason why I introduced the Corporate Crimes Against Healthcare Act to hold these executives accountable. So I wanted to be able to pop in here today just to talk to you a little bit about what's in this bill and to remind you there are things we could do at the federal government to stop this looting of our healthcare system and things we must do. Otherwise, they are going to hollow this system out and we're going to have nothing left. So I want to tell you about this bill. The title kind of says it all, the Corporate Crimes Against Healthcare Act. And here's the idea. First, it holds executives and investors responsible for looting healthcare entities by imposing criminal penalties on executives when their looting results in patient deaths. And I'll just give you an example of that. So that when these corporate executives decide to take life-saving equipment out of hospitals, when they decide to get rid of the people who operate the life-saving equipment, and someone is in the hospital and actually dies as the result of that executive decision, then that executive can be held responsible. In the same way that involuntary manslaughter applies in other places where you unnecessarily put other human lives at risk. And I think this has to be an important part of how we start looking at it. This is not just about money. This is about lives when they invade our healthcare system. Second thing this bill does is it gives the Department of Justice and the state AGs the power to claw back compensation from executives and from private equity investors that send their portfolio companies into a financial spiral down. The idea here is when you come into one of these hospitals, not to save it, not to manage it, not to make a little money over time or even a lot of money over time, but when you come in, just suck out the assets and take those assets entirely out of the healthcare system, using them instead for executive compensation and for distribution to the shareholders, and the resulting hospital goes down, then the AGs, state AGs, or DOJ can come take that money back from the investors and from the executives who took it out of the hospitals to begin with. And I say this with my Steward hospitals right now. Ralph Delatorre and his people took about $1 billion out of modest hospital chain in Massachusetts, 9 hospitals. What they could be doing with that $1 billion, that made it out to the executives and the investors is literally the difference between life and death for some people in Massachusetts and for the operation of that hospital. Third thing this bill does is it gives, it cracks down on real estate investment trusts, these REITs, which scoop up real estate from hospitals, nursing homes, and other facilities, and then saddle them with extractive rents. Again, I'll use the example of the Steward hospitals. After private equity came in, they sold off all of the entire real estate of the hospitals, which meant you go into one of those hospitals and the hospital literally doesn't own its building, it doesn't own its operating room, it doesn't own its gift shop, it doesn't own its parking lot, it doesn't own any part of it. And then they saddle it with a rent that literally makes it impossible for the hospital to survive, because they've got to manage the rent on what used to be the hospital that they own. And what did they do with the money when they sold it? They used it to pay off the executives and investors. In addition to that, under my bill, health facilities that sell or mortgage assets to a REIT will not be eligible to participate in any federal health programs. So that's how we get the muscle into this. Also, my bill significantly strengthens the data that healthcare entities must report, from ownership information, including mergers, to corporate structure and financial data. One of the things we run into when we talk to groups about what's happening, they don't even know that private equity moved in 6 years ago. Our nurses didn't know that they weren't working for the same organization anymore, and that someone else had come in and bought them. So the idea is here that we get more transparency into those transactions so that people know to ask more questions, and so that there will be more state supervision. Today, a patient cannot easily look up whether or not their community hospital or local primary care is owned by some private equity outfit, or is actually the doctors who are performing the services here. And I think that's something that we should fix. Together, these changes will hold private equity vultures accountable when they harm patients and communities. And importantly, it will empower regulators to prevent crises like the one we're seeing unfold in Massachusetts with the Steward hospitals from ever happening again. I wanted to be here partly just to say thank you for the advocacy work that all of you are doing, but I also wanted to be here to remind you, we don't just have to throw up our hands. We can actually change the law in this area. And if we do change the law, we can make a real difference in what happens in our healthcare system going forward. I'm going to fight for this bill, and I very much ask for your help so that we can get this done. So thank you all. Thank you. Thank you. Thank you.
All right. Well, we very much appreciate those remarks by Senator Warren, but now we can go to our panel. So first up is, as I mentioned, Dr. Eileen Appelbaum.
So first, thank you all for coming and taking time out of your busy day, and many, many thanks to Senator Warren for being there and providing the leadership for really preserving what we can of the healthcare system. So it is true, as Brandon said, that if you just look, and this is the big, by the way, the big propaganda campaign that's going on now by the lobbyists for private equity. We're so small. We only own 4% of healthcare providers and operations. How can we be making any problems? You regulators, go look someplace else. Don't be looking at us. And of course, the regulators have begun to look at them. And that's the reason for this campaign that they are engaged in. So I know that everybody in this room has some idea, and of course the senator just explained it, that private equity is not a force for good in hospitals and healthcare. But I want to take a few minutes to talk about first of all, the private equity business model, and then how they actually do enrich themselves. It's so that you have maybe a little bit deeper understanding of what private equity is all about. So Eileen O'Grady here is going to demonstrate for you all the ways that private equity has entered the healthcare system. And what they do is they look for the lucrative areas, the places where they can make money. They're not everywhere in healthcare. You know, that's where they get involved. And they are both opaque. They're private for a reason. They don't share information unless they are mandated to share it. Some of them are unscrupulous. You know, we do have private equity firms, usually smaller ones, that do try to provide, as they claim, financial information, operational information to the companies. That does happen. I don't want to deny that. But the big private equity companies don't have the time to do that, and they don't buy struggling companies. They want to be able to sell their company in 3 to 5 years at a profit. So you're not going to buy, that's not enough time to turn around a struggling company. I mean, the example you all know is Toys R Us, which, you know, it's a huge company at the time the private equity bought it. And then not so very long ago, it went bankrupt. So they're not buying little struggling companies. They're buying big companies that they hope they can, I'll explain to you the kinds of things they hope they can do to make it look better and then sell it at a profit. So that's really the big, the big story here. One of the things about the private equity business model itself is that the model itself opens the door to unscrupulous behavior that is legal, just shouldn't be legal. Okay, so we have legal behavior. They're not breaking the law. Some that break the law, they have fraud, that's another story. But without breaking the law, just using the private equity business model, it is possible for them to enrich themselves at the cost of everybody else. So the way it works is you have a private equity firm like KKR, Blackstone, Carlyle, some that you may not have heard of, Welsh, Carson, Anderson, these funds, they receive money from pension funds, from endowments, university endowments, other institutions, and wealthy individuals. And they promise that they are going to return better returns than you could get in the stock market for giving them your money. And then one of the things to know, so the firm sponsors a fund. The fund collects the money from all these different groups, and the firm itself puts in 1 to 2 cents for every dollar its investors put in. So it only has 2% of what's in the fund. It is at risk for the firm. And of course, as you have heard, they use a lot of debt when they buy a company. So let's say they put a 30% down payment and 70% debt. 2% of 30% is 6%. They have 6% of actually it's even lower because it's 0.2 times 0.3 is 0.06. They have less than 1% of the purchase price at risk of their own money. So very little skin in the game. And that's what allows them to be able to do all of the kinds of things that they do because they don't have very much to lose. And if they win, it's huge, right? If you put that little in and then you take the winnings, it's really huge. And so the last thing to say about that piece of it, about the fund, is that the fund is run by something called the general partner. And the general partner is not a person. The general partner is a committee of partners and principals in the private equity firm. So the general partner, which makes all the decisions, the pension funds have nothing to say about it. The general partner, which makes all the decisions, is part of the private equity firm itself. What the funds do then, as you've already heard, is they go out and they acquire companies, healthcare companies, and they use a lot of debt. 70% debt is not unusual. For comparison, the amount of debt in a durable corporation would probably be 30 to 40% debt, 60 to 70% equity, and private equity turns that on its head. It'll be 30% equity and 70% debt, and we have many cases where the debt is 80 or 90% of the deal. So they are playing with other people's money. The money is their investors' money and their creditors' money. And so they can be cavalier in what they do. they don't really care. They don't have to be that careful. They look for something that looks like it's going to be possible to increase the cash flow of that organization. The debt itself increases the cash flow because you can subtract the interest on the debt when you pay your taxes. And so your after-tax income will go up immediately from all the debt that you put on the company. You would think everybody would realize that this is just sleight of hand, that nothing really changed, but hey, looks very good. And then they plan to sell the other thing about that they can be cavalier is who pays back the debt. They buy the company, the private equity, they put all the debt on the company, and then it's the company that has to pay back the debt. It's like you buy your neighbor's house. You own your neighbor's house. Who pays the mortgage? Well, your neighbor pays the mortgage. But meanwhile, you own it. And if it goes under, whose credit rating is ruined? Your neighbor, not you. And so there's no shame involved. Often you don't even know what was the private equity company behind the bankruptcy. But they're not liable for any of it. And of course, debt is a two-edged sword. It increases the returns to the private equity fund, but it also raises the possibility of the company going bankrupt. These leverage buyout, they like to point to, in private equity owned companies, the bankruptcy rate is just about the same as it is for publicly traded companies. But that's not true for these leverage buyouts. When a buyout involves 70, 80, 90% debt, those companies have a 20% bankruptcy rate, which is huge because the bankruptcy rate in the US is very low, 2 or 3%. So, it's 10 times the bankruptcy rate. And so the question is, how do they make this money, all this money that we hear about? The first thing is asset stripping. The most common form of asset stripping is what the senator spoke about. You buy the hospital or the nursing home or the clinic, and you sell off the real estate to a real estate investment trust. These are evil financial players that nobody knows about. They're even more hidden than the private equity firms. And then the money, sale leaseback agreements are done all the time. But if you're a company and you do a sale leaseback, you get the money and you invest it, let's say, in technology or whatever you wanted to invest it in. But a sale leaseback with a private equity owned company, the health company gets the rent, and the money from the sale goes to the private equity firm. And as you heard, they manage to line their pockets with it. So that's one big thing, but it's not the only thing that goes on. There are other things that go on. Dividend recapitalizations, for example, are another way that they strip assets from the hospitals that they own. In the dividend recapitalization, the private equity owners require the healthcare company to take on more debt. And they take on that debt, and what do they do with it? They pay dividends with it. So the hospital or the nursing home has more debt now. The money goes out to the private equity firm. And the third thing they do is they charge the companies that they own what are called monitoring fees. This is so that they can oversee the company. We're charging you to oversee you. But in the industry, this is referred to as money for nothing because they don't actually provide any value for that money. And nevertheless, they obligate the healthcare company to pay it for years and years and years. So that's one big thing they do. Another big thing they do is that they consolidate local healthcare markets. As Brandon said, they're not like spread out all over the country. We have the example of radiology companies in Texas. A huge number of them in Houston were bought up by Welsh, Carson, Anderson, and Stowe. And before long, they owned a huge number of these companies in all of Texas. So if you were a patient, you really had no choice. You had to go to one of their companies to be taken care of. If you were a clinician, you had no choice. If you live in Texas, you're basically going to work for a practice owned by a private equity company. And once they do that, and they have this concentration in an area, they then can negotiate higher prices for their procedures with the insurance companies. And that ends up raising everybody's premiums. So healthcare costs go up, your premiums go up. and the private equity company is collecting those returns. And they now have a large footprint, they're getting these returns. This is very important to them because it raises their returns, it makes them look good, makes the company look more valuable when you go to sell it. But raising the returns is not the same thing as raising the profit margin. Because if in fact you staff those organizations properly, your costs are going to rise along with your revenues. So if you want to raise your profit margin, you have to figure out something else to do. And that something else is you have to cut costs. So you raise the revenues by raising the prices, but you raise the profit margin by cutting your costs. And what does that mean? It means closing down certain operations. Nobody wants to have a birthing place anymore. I don't know what expectant mothers are supposed to do, but they close down certain things that they think are not going to be profitable. And then the other thing they do, of course, they cut labor costs. That's a big part of it. So they lay off workers, they don't staff properly. You have nurses and clinicians and frontline workers who are overworked, who do not have enough time to spend with patients. And we already have the research that shows what happens, that when that failure to staff properly has led to premature deaths in nursing homes. You're more likely to die prematurely in a nursing home owned by private equity. And the research on hospitals finds that private equity owned hospitals are prone to all kinds of things that happen, falls that happen in hospitals, ulcerated sores, hospital-acquired illnesses. You get sicker in hospitals that are owned by private equity. So we know that cutting staff is not good for patients and it's not good for healthcare. So that's the other main thing that they do. And then we heard from the senator about bankruptcy for profit. I always say that they've collected so much money while they own the company that selling it at the end is the cherry on the sundae. They've already collected the money. They're happy if in spite of everything they've done, the company succeeds and they can sell it at a profit. But that is the cherry on the sundae. That is not the bread and butter. The bread and butter are all the fees that they collect. So what happens in those situations, as the senator said, is that the private equity guys and also the executives at the hospital frequently are in cahoots with them, and they walk away with all this money, and there's no way to do anything about it. The hospital goes bankrupt, the workers are out of work, the community doesn't have a hospital, patients have to travel long distances, but the private equity guys go away with $800 million in the Steward case. So, they found a lot of ways to make money at people's expense. And what we need are policies that can stop them. And one of the things that has happened is we do have regulatory agencies. And I will say that in the last few years, the regulatory agencies have begun to take steps to rein in some of the bad behavior. It's not just private equity. There are other big Wall Street companies out there that are making problems. And the regulators have begun to try to rein this in. And the Supreme Court has now made it impossible for the regulators to regulate them. I mean, the Supreme Court basically told the SEC that you can only regulate publicly traded companies when they try to have some more transparency around the privately traded ones, privately owned ones. So we cannot look to the regulators. We have to look to Congress. And so there are many people in Congress now trying to take steps that will help to rein in private equity. There are many calls for more transparency, which Brandon is going to talk about. There are the call that you just heard from Senator Warren to hold those executives responsible if their actions drive the company into financial distress or into bankruptcy. It should be possible to claw back their ill-gotten gains. And that bill would allow, and as you heard, if somebody dies as a result, which in the Steward Hospital, somebody did die. She was telling a true story there. But if somebody dies, then there will be criminal penalties, as there would be, in any case like that. And then, so that's the second thing. The third thing, which would be the most important thing if there were any way to get it, is to hold the private equity firms jointly responsible with the companies that they buy to repay the debt and for any illegal practices of those companies. You don't see it so much in healthcare, but you see it in other industries, supermarkets, for example, where there's just gross violations of labor law. People are paid not what they're supposed to be paid, and there are many other kinds of violations, and or in franchises, you know, the companies walk away clean, they don't have anything to do with it, and it's the local company that bears the burden of being sued or being taken to court or whatever. If they had to share that responsibility, two things would happen. One is they would load the companies up with debt the way they do. If you're going to be responsible for repaying it, if the company can't, you're going to be more careful about the debt. And the second is they're going to be a lot more careful about the practices of the companies that they buy, if they are going to be liable for any illegal actions those companies take. So that's the biggie, but it's a little hard to get that to happen. And then the last thing, which is probably an easier lift, is to make private equity work for its money. Okay, they get a lot of taxpayer money, especially in healthcare. They get it from Medicare, they get it from Medicaid. It's a huge subsidy to them. And they collect this money and they don't necessarily provide any services for it, or certainly not services commensurate with the money that they receive. And so what we can do, it seems like an easier lift, is to have specific policies that in place, legislation in place that will make them work for the money. If we're going to pay you, you are going to take care of the patients. And at CEPR, with Brandon and Emma, have put together a 2-pager that we shared with many offices here about what might be done for hospice. Hospice is a terrible case of just collecting the money. In hospice, the only obligation of the agency is to have a nurse visit the patient once every 2 weeks. But the good hospices do a heck of a lot more than that. But you get paid on a daily rate for every day that the person is enrolled, whether they get services or not. We could require that they provide more services than a visit once every 2 weeks. So that there are things like that that can be done that would be specific to the segment. So I'm going to wrap up by saying that what they claim is that they have to do this, they have to make all this money, they have to be mean and miserable and aggressive, because after all, the workers' pensions provide 30 to 35% of all the equity in private equity funds. Don't we have to make money so that they can retire in comfort and get their pensions? Well, we have 2 very recent studies that show that in fact, you could do just as well with the kind of, if you have an IRA, a Vanguard or someplace like that, they have you in a index fund that is 60% stocks and 40% bonds. Well, the Canadian pension plan took a look at how its pension has fared being actively managed and all these alternatives and doing all the, you know, the cool things that you're supposed to do and not having a plain vanilla pension plan. And what they discovered is that they lost over the 18 years that they've been doing this, they lost 0.1% on average annually compared to what they would have gotten with plain vanilla. They certainly didn't beat the plain vanilla plan, but they missed it by 0.1%. That may not sound like a lot of money to you, but if you look at it over the 18 years, given the size of the pension plan, that's $42.7 billion more than they would have had in a plain vanilla plan. They lost out on gains of $42 billion. Well, that's one thing. And then the Boston College Center for Retirement Research also did a plan. They did a 60-40, same kind of thing that Vanguard would do for you. And they found that it performed as well as private equity in general. Each returned since the year 2000, 6.1%. But since the financial crisis, the plain vanilla pension plans have done better than the ones that are in private equity and alternatives. Before that, you know, it went the other way, but it hasn't gone the other way. Private equity has not been in the market since the financial crisis of 2000 and 2009. So no excuse for their behavior.
Hello. Can you hear me right? Okay. So I'm Eileen O'Grady, as previously introduced. I'm gonna cover some of the areas, that, Eileen Appelbaum talked about, more sort of, in theory. I'm gonna talk a little bit about how they've actually played out in real life. Dividend recaps, high leverage, management fees, sale leasebacks. So I'll share another case study, in addition to the one that Senator Warren shared on Steward. We'll then delve a little deeper into sort of what the implications are for the aggressive use of debt that Eileen covered. I'll then briefly highlight a few areas where we see private equity sort of setting its sights. So some of the more emerging areas outside of the typical nursing home or hospital examples that I think you all have heard a lot about. So starting with the case study, Prospect Medical Holdings is a safety net hospital chain that has about 17 hospitals in 5 states, Connecticut, Pennsylvania, New Jersey, California, formerly Texas, although those hospitals did close. It was owned between 2010 and 2021 by a private equity firm called Leonard Green and Partners, which acquired it as a set of nonprofit hospitals in a leveraged buyout. Over the course of that time, Leonard Green engaged in all of the tactics that Eileen Appelbaum outlined, including using Prospect, we think, as a platform essentially to raise debt to pay out huge dividends to the private equity firm that owned it, Leonard Green and Partners. That included multiple instances of dividend recapitalizations where it took out debt on the hospitals and then used the proceeds from that debt to pay itself and investors upwards of $450 million. It was then highly indebted, needed to find a way to reduce that debt, and so it sold the real estate, again, to a real estate investment trust, that Properties Trust in particular, which some of you may know, also owns the real estate under Steward Health Care's hospitals. So Prospect no longer owned one of its most valuable assets. It had to pay rent when it didn't before to a corporate hospital landlord, which overall increased its liabilities, diverted cash away from being able to operate the hospitals. And you can imagine what happened. While Leonard Green was siphoning all this money out of these safety net hospitals, the hospitals suffered. The hospitals had some of the worst quality ratings from CMS. The hospital in Culver City, California had mold growing out of the walls of the nurses station, hole in the ceiling where rain came through. One of 2 elevators in the whole hospital was broken for over a year. Hospital in Waterbury, Connecticut had immediate jeopardy status for conditions that placed patients in danger. The Texas hospitals all closed down, and Leonard Green / Prospect sold that real estate to a luxury hotel developer. People obviously noticed what was happening, and they called on lawmakers, on regulators to do something about it. When lawmakers wrote letters to Leonard Green saying, we're concerned about how much money you're taking out of these hospitals and what the impacts are, Leonard Green responded that the company was, quote, well capitalized, doing just fine. Now we're seeing those hospitals starting to cut services, potentially close, lay off hundreds of workers. And Leonard Green, meanwhile, made literally hundreds of millions of dollars amid all of this. So that's the story of Prospect. And I want to step back and talk a little bit about another key component of this that Eileen already touched on, but I want to get into some specifics of bankruptcy. So this is debt. As you know, private equity firms really over rely on the use of debt, and they do it by loading the companies that they buy with debt. So they're not putting in very much of their own capital. It's well documented that PE firms use a lot more debt than publicly traded companies, and the gap between those debt ratios between PE-owned companies and publicly traded firms has grown almost every year. And part of what makes that debt so risky is something that Eileen covered, which is limited liability. So they are really not on the hook for the debt that they place on these portfolio companies. The companies are on the hook to pay it back. Sometimes it works out well for the private equity firm, but often it doesn't work out well for the company, and it certainly doesn't work for the patients and the healthcare workers at healthcare companies that are highly indebted. Leaves those companies more vulnerable to market conditions like a global pandemic, high interest rates, and we're really starting to see that play out much more dramatically with a recent wave of healthcare bankruptcies. So we put out a report earlier this year that looked at all the healthcare bankruptcies in 2023 and found that 20%, over 20% of them were private equity owned companies. And I just took a look at the bankruptcies that have happened for the first 6 months of this year. 24% of those were private equity owned companies. And I think this is particularly funny given the thing that Brandon said earlier about one of the industry talking points that we're hearing, that private equity firms only own something like 4% of the healthcare industry in the US. And if we're going to take them at their word, which I'm not prepared to do, but if we were, then it's especially staggering that they account for 20 to 24% of healthcare bankruptcies over the last few years. I think it's especially disturbing that even companies that are not filing for bankruptcy, companies that are highly distressed right now, have been still been taking debt-funded dividends. So taking on debt to pay their shareholders, even while they're teetering on the brink of defaulting. One example that I noticed last month was Ensemble Health Partners, which is literally a medical debt collection firm owned by a private equity firm that took out $800 million in debt to then turn around and pay that to their private equity owner. This is really irresponsible. It is disturbing. Bankruptcies, as Eileen mentioned, are more than just legal or financial events. They have real impacts on people's lives. They could lead to closures, job cuts, service cuts, and then they also have ripple effects on healthcare companies in those communities because patients who were seeing a physician at a practice or going to a hospital that then closes will go to another hospital, and those hospitals or healthcare providers suddenly need to pick up the slack. So I want to talk a little bit about where we see PE heading, because hospitals, nursing homes, I think have gotten a lot of really well-deserved attention. There's been really great research that shows what the impacts have been on patients. Hospitals in particular, we've noticed through our private equity hospital tracker, if you'd like to look it up online, private equity firms own 460 hospitals in the US, which accounts for about 8% of all private non-governmental hospitals. That's significant, but again, it's less popular these days for PE firms. So one of the things I wanted to highlight, just as an example of where we see a lot of investment activity by private equity firms, is actually the dental care industry through a business model called DSOs, or dental service organizations. And for people who are familiar with the corollary in physician practice management, it's very similar. They create management firms that nominally do things like administrative, marketing, business services for dental practices, but are supposed to not have anything to do with clinical operations, so as to not violate what's called the corporate practice of medicine. And one of the ways that we have seen this play out is private equity firms have essentially dominated the DSO market through hundreds of acquisitions that have happened over the last few years. This is a little out of date, but we did a study on this in 2021 that found that of the 30 DSOs in the US, 27 of them were owned by private equity firms. And I just kind of did a back of the envelope search earlier this week to see what it's like now. Of the top 9 DSOs in the US, 8 of them are owned by private equity firms. So we've seen a lot of consolidation in this space. What does this actually mean? Well, DSOs claim that they have no impact on clinical operations. They like to say that they're back of house. But regulators have found multiple times in multiple investigations that relationship is actually a lot murkier than they would have you believe. The owners, so private equity firms, often exert undue influence over clinical operations. setting revenue targets, profit sharing models, productivity bonuses that can lead to overtreatment of patients, pressuring for higher volume of patients. It might lead to unnecessary medical procedures. So one example we have of this, Cool Smiles was a pediatric dental chain owned by a private equity firm called FFL Partners. It paid a landmark Medicaid fraud settlement a couple years ago for allegedly providing medically unnecessary tooth extractions and root canals on babies. And in the complaint, the DSO alleged that the company, quote, routinely pressured and incentivized dentists to meet production goals through a system that disciplined unproductive dentists and awarded productive dentists with substantial cash bonuses based on the revenue generated by the procedures they performed. That is not safe. It is very disturbing to know that corporate dentistry led by private equity firms is rapidly expanding in the US. It's not the only place. Do I have time to talk about another example? I also want to talk about durable medical equipment, which for those who don't know, is meant to describe equipment that is prescribed by a healthcare provider for everyday use. So it's wheelchairs, mobility aids, diabetes supplies like testing strips, glucose monitors, things like that. I want to talk specifically about wheelchairs or motorized wheelchairs, actually more specifically custom wheelchairs. There are two companies that dominate the wheelchair market in the US, and they're both owned by private equity firms. They got that way because over the last 10 years, private equity firms went on an aggressive debt-funded buying spree to consolidate the wheelchair provider market into these two companies. And now those companies are highly indebted and they're looking for ways to cut costs. What does that mean for wheelchair users? Well, the cuts to staffing means that it takes a really long time for wheelchair users to get their chairs repaired. And those impacts can be incredibly dangerous. It can mean not being able to leave your house to get groceries, missing doctor's appointments, missing school, being stuck in your bed, which puts you at risk for bed sores. And I think what's really concerning about this is that there is legislation at the state level that is attempting to increase wheelchair users' ability to, one, repair their own wheelchairs, and two, to put more sort of oversight over wheelchair companies in terms of repair timelines, so that wheelchair users can get their chairs repaired more quickly. The industry associations that are leading the fight to push back against those proposed reforms are led by private equity-owned DME providers. And so they're fighting to preserve their right to cut staff, cut costs, and then take way too long for wheelchair users to be able to have their chairs repaired. This is potentially life-saving legislation for some people. There are a few other areas I just want to highlight that I don't think we'll have time to get into right now, where we've seen lots of PE activity. Fertility treatment, so fertility clinics, IVF clinics. There's a paper that came out recently that found that 30% of ART, assisted reproductive technology cycles, so it's basically IVF, 30% of cycles conducted in 2018 were at private equity-owned clinics. Clinical research is also really big, so that's clinical trial sites, contract research organizations, parts of the drug development industry, also a very popular target for PE acquisition just in the last couple of years. Physician specialties, I'm sure folks have heard a lot about dermatology, anesthesiology. Lately, we're seeing a lot more deal activity in cardiology, ophthalmology, gastroenterology. And you can see a lot of it is driven by opportunities for consolidation. Some of it is that gastroenterology, for example, is a very procedure-heavy specialty, so there are lots of opportunities to do procedures which make money, and couple that with the fact that there is a very well-documented rise in colorectal cancer, and that has caused more coverage for things like colonoscopies and other procedures. Lastly, behavioral health, and Eileen Appelbaum has written a lot about specifically autism treatment being also rapidly consolidated by private equity firms, also really harmful impacts on the people that those treatment centers serve. So we're seeing a lot of deal activity. We're also seeing the private equity industry fight back. I think as Brandon mentioned, as Eileen mentioned, private equity is engaging in a very explicit PR campaign to try to burnish its reputation in healthcare, specifically. And through that, they've attempted to downplay their presence in the healthcare industry using misleading data. And this is not new, to be clear. A couple of years ago, folks may remember 2 private equity-owned medical staffing firms spent $50 million on a dark money campaign to fight surprise medical billing legislation. So legislation that would try to curb surprise medical billing. Just last year, they spent $20 million on lobbying, and I think have had some luck in fighting laws and regulations that are designed to curb some of the worst practices of the industry. I think it is important to note that the private equity business model isn't the only thing wrong with the healthcare system. But I do think that it is an amplification of existing problems, and it is unique, as Eileen said. As some researchers have called it, it is a divining rod for market failure. And so for those reasons, we really need healthcare regulations to take transparency, risky use of debt, other aggressive profit-seeking tactics into consideration, and to protect patients and healthcare workers from the increasing impacts of healthcare financialization. And I'm going to end there because I believe Brandon is actually going to talk about that.
All right. This is working, right?
Yeah.
So first, I just want to, again, thank Eileen A. and Eileen O. here for giving such informative remarks. So when we talk about private equity generally, usually the questions surround why is private equity getting involved in the first place? What's the effect it has on the quality of care, the cost of care? And as we've heard, private equity gets involved to make money and make it fast. Often PE ownership is associated with lower quality, less access to services, and higher costs. But you might say, okay, well, we have like a market system. So in a market system, patients can recognize the problem with a private equity provider and then go to another one. There are several problems with this idea. One of them being, it presumes there actually is choice. As we've established, private equity seeks to consolidate and dominate local markets. So in those cases, there isn't much choice. Private equity also disproportionately with hospitals have bought rural ones. So if you're in a rural area and the private equity owns your hospital, how are you gonna go hours to get alternative treatment? But that's even a little too far, because at the most basic level, this assumes that patients can know the provider is owned by private equity in the first place. And that's not often a given. So earlier this month, on July 11th, in a Senate hearing, Senator Warren asked Dr. Christopher Whaley from Brown University how hard it would be for a patient to know if their neighborhood hospital or primary care physician was owned by private equity. And he said it would be virtually impossible. So virtually impossible. She asked a very similar question to the director of a union health insurance fund. And for workers there and the insurer herself, next to impossible. So we have virtually impossible and next to impossible. The SEC requires public disclosure of financial information for publicly traded companies. This doesn't apply, though, to private funds, private equities. When the SEC tried to implement a rule last year, increasing transparency between the PE firm and its investors, forget the public, the Fifth Circuit Court of Appeals said, no, you can't do that, you're overstepping your authority, just to show the regulatory landscape we're living in. So this lack of transparency doesn't just affect patients and workers and insurers, it also affects government regulators. So CMS, the Centers for Medicare and Medicaid Services, actually does collect ownership information from providers and suppliers that enroll with Medicare. And so in September 2023, the Government Accountability Office put a report looking at nursing homes and private equity, and it estimated that around 5% of nursing homes were owned by private equity. You might say, okay, well, that makes it sound like they do have access to the information. Well, if you actually read the report, they acknowledge that the figure is probably not accurate. Because, well, first of all, the ownership information that's collected doesn't explicitly say if an owner is private equity. Also, the data is often incomplete, or it doesn't acknowledge complex ownership structures. So in this case, we have GAO experts combing through CMS data, and they can't get an accurate picture. How are patients going to get an accurate picture? It's just not going to happen. So in November 2023, CMS put out a final rule. And most of it, this is what most of the public coverage of it was about, most of it pertained to nursing homes. It was implementing a provision of the ACA, only a short period of 13 years later. And that's after public pressure calling them out like you're not implementing the law that was just passed. And so for nursing homes, it required various parts of transparency, like ownership structure, members of board, financial services. But it also had a part of it that applied to all institutional providers that enroll in Medicare. And this component of it basically says now when you acknowledge an owner that has 5% interest, indirect or directly, you have to state if it's a private equity company and also a real estate investment trust or REIT, which is the entity that private equity often sells property or real estate off to. And so when I say indirectly, if you have a case where a company owns 50% of a hospital and then private equity owns 10% of that company, 10% and 50% is 5%, so in that case, they would meet the 5% threshold. So you might say, okay, well, then that rule addresses it. Now the government has access to the information. Well, like with many government or agency rules, there's a variety of limitations. First of all, the information doesn't just come like that. It's a provider or supplier has to fill out the form. It's called the CMS form 855A. Initially when they enroll in Medicare and every 5 years thereafter. So that means for the current set of providers, it'll take up to 5 years for the information to come in. Now they can do what's called an off-cycle revalidation and collect it sooner. And they've expressed some willingness to do that with nursing homes. That's what the rule is mostly for. But there's no inclination they'll do that for all providers. So, okay, fine, the information is not going to come fast, but is that it? Well, no, another limitation is, okay, so the government gets the information. What about the public? I started this by talking about patients. So the information on nursing homes will be made public because the ACA says it has to be made public. The authority to collect the information for institutional providers comes from a very broad power, actually dating all the way back to 1977 in the Medicare and Medicaid Anti-Fraud and Abuse Amendments. That basically says that the secretary has the power to collect complete ownership information. This doesn't say anything about having to make it public. Now, the Biden administration since 2022 has voluntarily started making information available for hospitals, nursing homes, home health agencies, and hospices. And so you might, okay, so they might expand it, but we don't know. Also, that information doesn't include the private equity data, and presumably it'd be reasonable to say they'd add it, but again, we don't know, and we don't know how long it would take. Again, these aren't the fastest moving bodies. And then, okay, well, how about can patients access, like, is it friendly to patients? Also, it's another question you have to ask. So if you look at the databases that do exist, they're good for the government maybe, and maybe researchers, but they're not the most patient friendly. So even if you have the information and you make it public, is it actually usable by the people who need it? Maybe not. I would say no, but it's up to your own interpretation. Okay, that's the second limitation. A third one, I said institutional providers, because this only applies to those institutional providers that fill out this very specific form. So if you have a physician's practice, it doesn't apply to them. So okay, it doesn't even apply to everyone. Another big limitation is just inherent in agencies in general. So like I said, it took 13 years for them to finalize the provision of the ACA into a rule. And then the original power came from 1977 and private equity emerged in the 2010s. And it took, again, many years for them to react with a rule. So agencies aren't the fastest. But also, because there isn't an explicit congressional mandate about private equity disclosure for all institutional providers, what's to say the next administration or next leadership at CMS chooses to not implement it? They don't even have to fully revoke it. They can just they can be slow as they want, but they might not even fully implement it. So this shows the importance of congressional mandates. An example of a congressional mandate that furthers transparency is the Corporate Crime Against Healthcare Act. So that would require collection and disclosure of ownership information, changes in ownership, mergers, acquisition of 5% or more directly or indirectly. And this disclosure would account for business types. So presumably, this would also include designation of private equity. And the law specifically states that it would require public disclosure. Now, how patron friendly it is, again, we don't know. But it does say that. And another big thing it says, which again shows the importance of specific language in bills, is that it says you must start collecting the information but no later than January 2026, and you must publicly release it no later than January 2027. The importance of this is so we don't have an ACA situation where it takes 13 years to implement a rather small provision of a gigantic bill. And so far I've just been talking about ownership. There's also no transparency with how much debt providers have. What the fees are the private equity firm is charging on the dividends they collect. So this bill would also address those things. So overall, to recap, we have a situation where private equity wants to, their primary purpose is not to, help people. It's to make money, make it fast. They use debt to do so, debt they're not actually liable for, which is something I wish I could do. Only they, they do it a lot. They then only own the provider or company for like around 3 to 7 years, and they can make a lot of money even if that company, in this case, a provider that patients rely upon, goes under. They're not subject to the same regulatory scrutiny or transparency as others. And that leaves patients, workers, insurers, and government regulators all in the dark. The agency action by CMS will help with transparency, but again, it is highly limited, and it really emphasizes the need for congressional action, and congressional action that involves explicit, specific language, because guess what? Private equity will find whatever loophole there is if you leave it there. So explicit congressional mandates are what would be required. And with that, I think we can move on to Q&A. And again, I warn you, please ask questions or you'll listen to me. So if you have any questions, Emma will hand the mic over to you.
It's on. Yes, you talked a lot about the private equity side of things. Where are these creditors come from? Why are they giving so much credit to these private equity entities? And just allowing them to take a profit on this debt?
So that is a really good question. Envision went under. This wiped out many, huge amount of the creditor investment or lending here, and you wonder why they come back. It's a very good question. So when it comes to the banking system, there now are some constraints on them. There are guidelines for how much that you can put on a company. And in fact, the result of that's been in place for a decade by now. But the result of that has been the growth of private equity debt funds. So private equity not only has buyout funds, but it has, they're sometimes called credit funds, sometimes called debt funds. And you want to do a leveraged buyout, you can do it, everything private, by going to a private equity company that has one of these funds. And the interest rates they charge, I mean, they have worked it out that they think they can get money. They assume, I don't think anybody assumed that Vigil was going to go under. Actually, private equities did a lot of things to help the really big lenders. Not worth talking about it here, but they saved the really big lenders, and they stiffed the vendors, the smaller lenders, anybody who was not likely to lend them a whole lot of money the next time. But in general, now we know very little about it. So if you go back a few years, there's a thing called PitchBook data, which a lot of us use, and you could look up the acquisition of a company by a private equity firm, and it would tell you what the acquisition price was, how much debt was used. But now that it passes through private equity on both sides, you don't get any information. The amount of information that researchers have has gone down tremendously because in fact, banks are a little squeamish. The banks, of course, feel like they're losing out because, I mean, if you have 20% bankruptcy, you have 80% success, right? And if the interest rates are high enough, you can make this work. And the banks are now unhappy that they are not making these loans. And so they have formed their own private equity units, or private debt units, really, to compete with the private equity debt funds and be off the books of the banks. So, but why they do it is a good question, because there is a fairly high bankruptcy. It is a risk.
I know you're all researchers and the information that you provided was fabulous, and terrifying. I'm not sure I'm addressing this to the right group, but I will anyway. Our medical providers, doctors, nurses, all the people who work in caregivers, are they organizing and against this? I see somebody in a white coat right here.
She's right next to the person who can answer that question.
Okay. Yeah, we're organizing. So there's a really deeper root cause than just private equity. The root cause is the corporate practice of medicine, meaning medicine being practiced by corporations that are not physicians. Can't get away with that in a law firm. Why is it allowed to happen in medicine? There are a number of organizations that are working really hard to try to take it back. Physicians for Patient Protection, Take Medicine Back, the American Academy of Emergency Medicine Physicians, which is where this corporate practice of medicine really happened and really began, was in emergency medicine. There's a lot of people working really hard to try to do the right thing, and we're here to help.
I would also just add, we have started to see nurses also fighting back, primarily through their unions. I just read a report, released last week by AFT, which, then, you know, is the teachers union, but also represents nurses around the country, just put out a report examining their pension systems, top, asset managers, private equity asset managers, so all the teachers' pensions and the nurses' pensions represented by AFT. Where are the private equity firms that they're investing in, and what is their impact on workers? And they specifically highlighted healthcare as a major risk to nurses and a major concern to the fiduciaries of these pension funds that are contributing the capital to raise the hospitals.
Did you have a question? No.
There are online questions.
Yeah, I was about to.
Mhm.
So yeah, we've gotten online questions. I'm gonna read one out. I'm an emergency physician and past board member of the American Academy of Emergency Medicine, which represents 8,000 plus practicing emergency physicians. And we were formed in 1993 to stand up against the corporate practice of medicine, which is now dominated by private equity-backed firms. How will this legislation, I assume the corporate practice healthcare act, help preserve emergency medicine specifically, which is the safety net of our broken healthcare system?
Well, we know that I mean, if they can hold the private equity companies responsible, the ones that, for example, of course, went bankrupt, but KKR had owned Envision, Blackstone owns Team Health. I think if you can hold them responsible for what goes on in the emergency rooms, that will be, you know, that'll be one way of doing something about it. I think the way that the doctor here explained to us, where the doctors themselves rise up and say, hey, this is not the way we want to practice medicine, is probably going to be very effective.
Because the groups that have been driven into bankruptcy, Envision, et cetera, are not innocent groups. Those are not groups of doctors. It's a corporation.
that's practicing medicine without a license to do so. And AAEM just ran them out of California. That is the American Academy of Emergency Medicine, just won a lawsuit to keep them out. And they are out of California, and hopefully we'll be able to get them in other states. So stopping the corporate control of physician groups is the way that we take medicine back. And that's ending the contract management groups like Envision and Schumacher and Team Health and Apollo, so that the physician-patient relationship is not disrupted, that remains sacred as it should be.
I would just like to know, we got a online comment saying that there was a part of the ACA saying it needed to be implemented by 2 years. I don't know if this applied to the prison, but if it did, that just makes me more depressed that they're supposed to, and CMS didn't do it. We have another online question. But I don't know how well we'll answer it, but how realistic is it this wonderful bill will pass considering the immense opposition from Republicans and most establishment / corporate Democrats? Well, I can't be overly political in my answer, but yeah, I'll defer to my.
Well, I know how we got rid of the surprise medical bills. And that was that we were able to mobilize community rage. I think that's what has to happen. It was so bad, the bills were so high that local newspapers all over the country were running stories about it. And so we, at CEPR, we produce a lot of research on the surprise medical bills. And we shared, we're not a lobbying organization, we shared it with Families USA. They were a major partner in getting it through the Congress. And then we did publish op-eds in local newspapers. Wherever we saw an article about it, we tried to publish an op-ed in that newspaper, and people just spoke to their Congress people. They said, this is outrageous. It's supposed to be, how can you have a bill like this? And so really, I think that to get something like this passed, and I do think that the failure of the Steward medical system, of Prospect Medical, people see this in their communities. You don't have a hospital to go to. Eastern Massachusetts is in trouble. They own hospitals in towns up and down Eastern Massachusetts. So maybe it's a small percent of all hospitals, but in Eastern Massachusetts, it's where you went to get health care, and now it doesn't exist. So if people, if we can mobilize that rage, if we can write the op-eds, if we can get people mobilized, and they go and speak to their Congress people, I do think that's how we got it passed. Somebody has to do the research, and I think that's been done. Somebody has to introduce the legislation. I think that's been done. And now what we need is a lot of pressure from people in their own community, talking to their own Congress people, saying this has to be dealt with.
For any like stoppers in the room to share what you learned today with your member, because most members maybe don't know that this might be happening like in their own communities. So
It's also an issue that unites Republicans and Democrats, because a lot of this is going on in rural hospitals where you only have a hospital, and if something happens, it's really bad. And so many people in Congress who represent rural districts have this on their radar. And I do think, I mean, stopping these surprise medical bills was a bipartisan effort. It's not a fest for just one party. And I do think that some of these things can also be bipartisan.
I would just add that, if you do work for a member who's curious about whether this is happening in their district, feel free to email me and ask, because, one of the things we do is we try to figure out where this is happening and what it means for real people. Private equity firms rely on the opaqueness of the industry and the fact that it is really hard for regular people to wrap their heads around. I think partially because so many aspects of the industry are absurd. And so please do look me up and ask, because I like to be helpful.
Another question we got, someone online, was why do physicians agree to be bought out by private equity at all? If they know the problems are occurring.
I think that there are a variety of reasons, some of which are just related to the fact that a lot of physicians are tired of running their practices and they want to sell their practice. Private equity firms are pretty aggressive about attempting to make offers to physicians. I think that it's worse in, for younger doctors who have trouble starting their own practice. They are, dazzled by investment that sort of comes in and positions itself as providing much needed capital for young physicians that, may still have debt from medical school. I think that more sort of financial incentives, like profit sharing arrangements, giving physicians equity, some amount of non-controlling equity in the practice after a private equity firm buys it out. Those are the main reasons that I've heard of.
Right, and they often don't understand what they're getting into. So they don't understand that they are going to be judged by how many patients they see, for example, or how many procedures they perform. That they don't understand what the pressures are going to be. It is becoming more and more known because doctors who are unhappy with what happened tell their colleagues from medical school, well, don't do this. So I've seen that, I've already seen that happen myself. But the other thing is, we have the corporate practice of medicine everywhere. It's not just private equity. So if you think about United Health Group, which runs these Medicare Advantage plans, which are neither Medicare nor an Advantage, they are insurance company plans. Have you ever dealt with your health insurance company? You already have an idea what that means. But anyway, United Health Group owns 90,000. It owns enough doctor practices that it controls 90,000 physicians in the US. So if you're not working for private equity, you might be working for a health care company. And then the hospitals themselves have become corporatized. So you have a situation in which the doctor is considered a doctor of that hospital, but they're not actually on the payroll of the hospital. The hospital has set up one of these companies, just like the private equity guys do, to manage the practice. And so you are working for a practice owned by the hospital, but you are not a hospital employee. And you're subject to the exact same kinds of pressure. So, what are their alternatives? I did actually have the opportunity to talk to a person who was graduating as an emergency room, emergency department doctor. And I asked him about it. And he said, well, the contracts don't look any better with a hospital than they do with private equity. And there's a lot more money for private equity. So why wouldn't I go with private equity? It's like, it's that kind of thing. So really, people don't understand what they're getting into. And when they do understand it, those practices refuse. You don't have control over building. I have one doctor that I see, the ophthalmologist, and they were courted by private equity, but they don't announce that they will take care of you for free. If you show up in your office and you need an operation to prevent you from going blind, they don't say, well, you don't have any money. I can't do the operation. This is a practice that will take care of that patient, even if they don't have any money. And if you're owned by private equity, you give up the ability to make those kinds of decisions. And that was the reason they wouldn't go. So I was very happy that that was my practice. But they did tell me about that. They know the research I did, so they told me that story.
Another question we got, it was asking specifically if Medicare for all would help with addressing private equity, but I think we can broaden that to, can insurers help guard against harmful impacts of private equity?
Yes, well, I'm sure Eileen will have something to say also, but the whole point of Medicare Advantage is it's not Medicare. And more than half of seniors have been tempted into it by all kinds of promises. Yes, they give you free gym membership, but you know what? If you have cancer and you need expensive care, go fight with your insurance company to get it, I worry I worry that the Medicare for all people are not paying attention to what is happening in healthcare. There are a lot of reforms that we're going to need. Because otherwise, we will have Medicare for all, and the taxpayers will be paying even more to the private equity companies, the health insurance companies, the corporatized hospitals and patient care. It may be more accessible, but it's not going to be of higher quality. So there's a lot that needs to get done.
I just wanted to follow up on the Medicare Advantage. I've been told, and if this is correct, it's important to get it out, that if a person eligible for Medicare signs up for a Medicare Advantage, there are many barriers, if not prohibitions, once they discover this, for them to be able to flip to just a regular. Is that accurate?
It is accurate, and here's what the issue is. So once a year, you can make the switch, but here's the problem. If you find out that you have cancer or you need something and you can't get it from the Medicare Advantage plan, the thing about Medicare is that it pays 80% of your medical costs. The other 20%, if you can afford it, you buy a private insurance plan. The private insurance plan is not going to take you on because they already know that you're sick or you're high, you're likely to be sick or you have things that indicate it. So that's one problem. And the other problem is that in order to get more money, the Medicare Advantage plans upcode. They make you look sicker than you are. So now, even if you have, let's suppose you saw a friend have this problem, you decide, hey, I'm going to switch. You have no idea what the Medicare Advantage plan is put on the record. And they have every incentive to make you look sicker than you are, because the sicker you look, the higher the payment from Medicare that they get for taking care of you. So now you have the same problem. The insurance companies don't want you. So, oh, and the other thing is, in Medicare Advantage, there's an out-of-pocket annual limit. In traditional Medicare, no limit. So you could be on the hook for, $100,000. But you can't get the insurance, the private insurance wraparound. You say, okay, I'm gonna take advantage of it anyway, but depending on what you need, your 20% could be huge, and there's no cap. And we cannot get CMS to deal with this because CMS is dedicated to Medicare Advantage and those kinds of plans. You may have heard about ACO REACH. So they're trying to, they've already announced, CMS has already announced it wants every retiree in some sort of plan similar to Medicare Advantage by the year 2030. They wait, but I tell you how they're gonna get you. That's what I wanted to tell you. So you are in traditional medicine. They get your hospital or your doctor's practice to enroll in ACO REACH. They look at the claims, they get all the claims, right? And they see who are the patients. They get 3/4 of their care at this hospital or from this practice. And you are attributed to the ACO REACH program. You have never signed anything, you don't even know anything about it. And in the ACO REACH program, at the end of the year, if these 75% of the people who are being seen by this practice, so that are being seen regularly by the practice, cost less to care for than was expected, then the practice or the hospital gets a kickback at the end of the year. So the idea, the CMS is under the illusion that this will make the hospitals treat you better, keep you healthier, and then you will cost less, and that's how they will make their money. But we all know that an easier way to make money, and private equity does it all the time, is to deny, and so does the United Health Group, deny service. You deny service, and then it comes out lower. I'm at a hospital. I don't get 75% of my care there, but I'm seen twice a year. I was being seen twice a year. I get a shot twice a year. And suddenly my doctor says to me, oh, you seem stable to me. I only have to see you once a year. I don't know whether it's because the hospital is an ACO REACH hospital. And he figures I'm not going to die if he only sees me once a year instead of twice a year. But the truth is I get a blood test before I get the shot. And I had a lot of questions about my blood test. I wanted to have my appointment with my doctor to be able to discuss them. And okay, you can ask a question through the portal. Actually, I saw him, casually, and I asked my question. I got a 1-second answer. It didn't really help me. So I will never know. I will never know. whether he really thinks I'm stable and only have to see him once a year, or whether they're saving the money on that second time that I saw. I'm still getting shot, but I need the shot, right? But I'm not seeing the doctor. That's my little $240 that the insurance company would have paid for me. That's gonna be a shared saving by this hospital. So, I'm with you, but CMS is against us. I've done my best. I've really done my best to bring this to public attention.
We have, oh, so, yes, we can take one more question.
Great, thank you so much. I'll be quick. Thank you so much for doing this. I work for the Joint Economic Committee and the chairman's really committed to making sure that private equity hospitals in New Mexico are also regulated and held to account. As we've seen also on the map that you provided here, there is a large concentration of private equity hospitals in New Mexico. So, thank you again. Just a very quick question on how private equity presence in the healthcare system is impacting rural healthcare specifically, and what more do you think we can do about
that? So I mean, I think we have seen a lot of private equity investments in rural hospitals specifically over the last few years. The largest rural hospital chain in the country, which is called LifePoint Health, is owned by a private equity firm called Apollo Global Management. We have seen Apollo, so it's relatively recent acquisition, but we've seen LifePoint under Apollo's ownership engage in some of the same strategies we've seen at more of the urban hospitals, including selling off in the real estate, expanding through debt-funded growth, diversifying their service lines, but not necessarily service lines that are beneficial to the people in those communities. And so I think I would answer that question mostly in pointing out that there has been a large number of private equity investments in rural communities, both in hospitals, behavioral health, addiction treatment, disability services, and the impacts appear to be the same in terms of cost cutting, reducing staff, high levels of debt that can divert cash away from operations. But in rural communities where there are fewer alternatives, those impacts are much more pronounced.
So I would just add that the rural hospitals are in big trouble. They're really in big trouble. They don't have the money to invest in their facilities. They can't get the kind of care that they would like to give. And one of the ways of saving them is to allow them to be acquired by a chain. This may have, I mean, there are, of course, all the antitrust and monopoly issues that it may be the only way to do it, but they have to be regulated. I mean, if you think about the telephone company, when it was a monopoly, we regulated it. And so if we're going to allow monopolies, we have to think about it in the same way. Because in some instances, there's really no alternative. They do raise prices. I've seen the study. I don't want to preempt it. It's not been published yet, but it does show some positive effects of letting a failing company be bought by a chain. But I don't think they distinguish between private equity chain and other chains. So I'll have to wait for the final version of the paper, but it is a very difficult question. It really is. The hospitals are needed. They don't have the money to invest in themselves. We just put out a report at CEPR called, it just came out this week. It's called the structural determinants of health. We all know about the social determinants and they're very important. But have you thought about the hospital building that you go into? Those services are provided within a building. And if that hospital does not have the money for modernization or expansion or adding outpatient services or a whole variety of things, then care is going to be inferior. And in fact, you can see the results in terms of healthcare outcomes. There's also a lot of built-in racism here because basically hospitals are raising money, nonprofit hospitals are raising money in financial markets. And if you ever bought a car and had to get underwritten, You have an idea of what kinds of questions they ask. And you have an idea of who actually gets the car loan and who doesn't get the car loan. And it's not too different for hospitals. If you're a hospital serving a Black community, you have to be underwritten by the financial services organizations. You're not as likely to be able to get the loans that you need to be able to do the construction. And the rules that we have then turn out to negatively affect the rural hospitals as well. They are under the same situation. To get money to invest, they have to go into financial markets. We do a little bit for the rural hospitals. We give them higher pay, the payments for care of patients, a little bit higher with the idea this will give them better cash flow and we'll be able to borrow money. But it hasn't been enough. It hasn't been enough. So we actually have a chapter on rural hospitals in that report. So it's a problem.
Well, that, I think we can call it. But first, I want to thank everyone involved. So our co-sponsors for the event, the CEPR, the Private Equity Stakeholder Project, United for Respect, Human Markets Institute, American Economic Liberties Project, and American Financial Reform. And I would also be remiss if I didn't thank Emma Kirchen, who's here, and her help with the event. Lisa Burnham is here, who's running social right now and helping record this. And our panelists, of course, and everyone who could attend in person and online. Thank you so much. And thank you to Senator Warren and her team.